Hey everyone, welcome back. Today we're diving into a topic that pops up pretty often in both exams and clinical practice, cholecystitis. So grab your notes, settle in, and let's walk through this together like we're chatting in class or on the floor. But before we begin, check out our extensive nurse test bank to help you pass nursing school and the NCLEX. The link is in the description below. Cholecystitis. That's inflammation of the gallbladder. The gallbladder is that small, pear-shaped organ tucked right under your liver. Its main job is to store and concentrate bile, which helps digest fats. When something blocks the normal flow of bile, like a gallstone, infection, or even thick bile sludge, inflammation begins, and that's what we call cholecystitis. It can be acute, sudden and intense, or chronic, when repeated inflammation leads to scarring and a shrunken, poorly functioning gallbladder. Now, what causes it? The most common culprit, hands down, is gallstones, also called cholelithiasis. They can obstruct the cystic duct, that little passage that lets bile flow in and out. When bile can't drain properly, pressure builds, bacteria may grow, and the gallbladder wall becomes inflamed. Other contributing factors include infection, tumors, trauma, or even major surgery that causes bile stasis. Long-term fasting or total parenteral nutrition can also lead to gallbladder stasis. The bile just sits there and thickens. And don't forget obesity, female gender, age over 40, pregnancy, and high-fat diets. I always remember the 4 F's: female, 40, fertile, and fat. It's a classic nursing mnemonic to remember who's at risk. So, what might our patient look or feel like? Let's talk manifestations. A typical patient with acute cholecystitis will complain of severe pain in the right upper quadrant, especially after eating a fatty meal. That pain might radiate to the right shoulder or back, and it's often accompanied by nausea and vomiting. Some describe the pain as sharp and steady, lasting several hours. They may have fever, chills, and abdominal tenderness. When you press on the right upper quadrant and ask them to take a deep breath, and they suddenly stop inhaling because of pain, that's Murphy's sign, a hallmark of cholecystitis. You might also notice abdominal distension, indigestion, and sometimes jaundice if bile flow is severely obstructed. Chronic cholecystitis tends to have milder, more recurrent attacks. The pain may come and go, often after large meals. Alright, let's talk about how we actually diagnose this. The healthcare provider will start with a thorough history and physical exam. The most common imaging test is an ultrasound. It's quick, non-invasive, and can show gallstones, thickened gallbladder walls, and fluid around the gallbladder. Sometimes a HIDA scan, that's a hepatobiliary immunodiacetic acid scan, is ordered. It checks how well the gallbladder fills and empties bile. If the gallbladder doesn't fill properly, that's a red flag. Blood tests can also help. We might see an elevated white blood cell count indicating inflammation, and elevated bilirubin, alkaline phosphatase, or AST and ALT if there's bile obstruction. In severe or unclear cases, CT scans or MRI cholangiography can be used to get a better look at the biliary system. Now let's move on to nursing actions. This is where you really come in as the patient's advocate and caregiver. The first priority is pain management. These patients are in serious discomfort. Analgesics are given as ordered, and keeping them NPO helps rest the gallbladder and prevent further stimulation. You'll usually insert and maintain an IV line to provide fluids and electrolytes since they can't eat and might be vomiting. Antiemetics help with nausea, and antibiotics are often started if infection is suspected. Monitoring vital signs and watching for signs of sepsis, like increasing fever, tachycardia, or hypotension, is essential. You'll also want to assess for signs of bile obstruction, such as jaundice, dark urine, or clay-colored stools. Positioning can make a big difference too. The patient might feel more comfortable sitting up or in a semi-Fowler's position. And don't forget the power of patient reassurance. Speaking of surgery, let's talk treatment. The main goal is to decrease inflammation, control infection, and remove the cause. For mild cases, conservative management with fluids, antibiotics, and rest might be enough. But when gallstones are the cause, the definitive treatment is usually a cholecystectomy, removal of the gallbladder. Nowadays, this is often done laparoscopically, called a lap chole, which means smaller incisions, less pain, and quicker recovery. Sometimes, if the patient isn't stable enough for surgery, a cholecystostomy tube may be inserted to drain the gallbladder temporarily. After surgery, nursing care continues to be, vital. You need to monitor for infection at incision sites, bile leakage, or bleeding. Encourage early ambulation to prevent complications and deep breathing exercises to prevent pneumonia. If the surgery was laparoscopic, shoulder pain from the CO2 used to inflate the abdomen is common. Walking and ambulation help relieve that discomfort. For open cholecystectomy patients, recovery takes longer, and you'll need to monitor drainage from T-tubes if used to ensure proper bile flow. Now, let's chat about patient education, which is honestly one of the most important parts of nursing care. Patients often ask, "Can I live without a gallbladder?" The answer is yes. The liver will still make bile, but instead of storing it, bile will flow directly into the small intestine. That said, patients might have difficulty digesting fatty foods at first, so you'll want to teach them to eat smaller, low-fat meals. Encourage them to avoid greasy, fried, and spicy foods, especially right after surgery. They should also maintain a healthy weight, stay hydrated, and incorporate high-fiber foods to help digestion. For those managed without surgery, it's really important to teach them the importance of taking antibiotics exactly as prescribed, reporting any worsening pain, fever, or jaundice, and making sure they attend all their follow-up appointments. If they have a T-tube, you'll want to show them how to care for it, like keeping the area clean, monitoring the output, and reporting any sudden changes in color or volume. Let's also remind them to keep an eye out for signs of complications, such as persistent vomiting, severe abdominal pain fever, or signs of bile peritonitis. Things like a rigid abdomen or increasing tenderness. These symptoms require immediate medical attention, no question about it. And for long-term wellness, encourage regular exercise and maintaining healthy cholesterol levels, since high cholesterol definitely contributes to gallstone formation. By understanding all of this, the causes, the signs, the nursing priorities, and the treatments, you're really equipping yourself to provide confident and compassionate care. Patients with cholecystitis can go from miserable pain to complete recovery, and nurses play a huge part in that journey. And that wraps up our deep dive into cholecystitis. You now know what causes it, how to recognize it, what to do as a nurse, and how to educate your patient for long-term wellness. If you're reviewing for the NCLEX, keep practicing those signs and nursing priorities. And remember, once you see right upper quadrant pain after a fatty meal, think gallbladder. Thanks for hanging out and learning with me today. Keep going, keep studying, and I'll see you in the next nursing review session.